So just as a review in terms of anatomy and physiology, trachea breaks into, this is the right side, this is the left side. When you look at chest x-ray, it's always opposite than what you are. So this is the right side. The trachea breaks down into the right main stem bronchus. There are 3 lobes on the right side. There's a right upper lobe, there's a right middle lobe, there's a right lower lobe. On the left side, there's a left upper lobe and a left lower lobe, and then there's a lingula, which is sort of the middle lobe. They don't call it the middle lobe, they call it the lingula, just to make sure you know what you're talking about, I guess. But anyway, so as you come down the trachea, you break off into the right main stem bronchi, the left main stem bronchi, and then you have all your subdivisions going to the different lobes. And then as you get down further to the alveoli at the terminal bronchioles here, you have all this nice smooth muscle, and then your alveoli look like grapes. And that's the reason why they look like grapes is so that they can expand and give you much more surface area than, I mean, if you think about it, if you think about one big balloon versus 20 little tiny balloons, if you look at the surface area of all those balloons, the 20 little tiny balloons has a lot more surface area than the one big balloon. Just as an aside note, the way that albuterol works is that it's a smooth muscle relaxant. So it actually works right here on the terminal bronchioles to make them relax, to open up the airway. That's the mechanism of albuterol, which we use all the time. Okay, again, just review of physiology a little bit. Tidal volume is what we're all doing right now. We're sitting comfortably, we're breathing in, we're breathing out. We're breathing in, we're breathing out. That's our tidal volume. Normal tidal volumes are around 300, 400 cc's, something like that. Minute ventilation or minute volume is how much do you breathe in and out on a minute basis? How many liters do you end up breathing in and out every minute? And it ends up being about 5 to 10 liters per minute, somewhere around there. That's a normal minute ventilation. Peak inspiratory flow is when you take a really deep breath in, how much airflow is achieved through the nose in that forced inhalation. Functional residual capacity is the amount of air in your lung present when you force exhalation. There's my functional residual capacity right there. And I'll show you in picture form what that is. Inspired oxygen, FiO2, that's pretty straightforward. Work of breathing is the amount of effort required by the diaphragm to breathe, to bring the air in and out. So pictorially, this is what it looks like. You probably have all seen this type of diagram before, but the thing that I sort of want to focus in on here is your functional residual capacity. So here's your tidal volume. You're breathing in and out, in and out, in and out. There's you taking a deep breath in, and there's you taking your deep breath out, and then you go back to breathing normally. So functional residual capacity is when we completely exhale all the way out, what we're left with is this residual volume here, and at the end of normal tidal volume, down, including residual volume, there's your functional residual capacity. So it's the expiratory reserve volume, which is right here, plus your residual volume, which is here. Normal values for men, a little over 2 liters, and for women, it's a little less than 2 liters. Functional residual capacity decreases when we're lying down, when we're overweight, during pregnancy, and during anesthesia. It's not uncommon that I have somebody coming into to my office and they say, "Doc, I can't lie flat anymore." But they write it off. It's not a concern to them, actually. They say, "No, I haven't been able to sleep in my bed for years. I sleep in a chair. You know, I'm reclining now, a recliner chair. I just find it more comfortable." And the reason why they find it more comfortable is because when you go flat, when you go in a supine position, your functional residual capacity decreases significantly because of all the weight that you have on. I mean, not only does it decrease, but now you have external weight sort of pushing down. Your diaphragm has to work a whole heck of a lot harder because it doesn't have gravity now to help it open up, and so they just can't breathe. And they find it much easier to sit up in a chair because now they're sort of at an angle, and so the diaphragm can work a little bit better. So that should be a key sign. If somebody cannot sleep in bed, if they're sleeping up in a chair or needs to sleep upright a little bit, that there's something wrong with their pulmonary physiology. Whether that's sleep apnea or something else, I don't know, but there's sort of something wrong with their physiology. It could be CHF. The aim of CPAP is to increase this functional residual capacity. So what happens is as you push in the air, this is an airway that's not completely open. So as you push in the air and you sort of extend it open, you allow the alveoli to remain open. It increases the surface area. It allows for more area for gas exchange. It improves the oxygenation, and it improves the ventilation. And this is just a picture in terms of what it looks like when you push air in. It allows these alveoli to remain open and gives you more surface area. Surface area is, I love equations. So I threw in a couple equations, but surface area, if you remember back to, I don't know, what grade were we in when we took geometry? 8th grade. I was going to say 7th grade, right? So 7th to 8th grade, somewhere around there, right? So the spheres, yeah, they said there would be no math, right? The sphere surface area is 4 pi r squared. So it's directly related to the radius. R is radius. So if you have an airway that's, I don't know, radius of 1, and you increase the airway 3 times that, your surface area, your sphere now, increases by 9 because it's radius squared. 3 times 3, 9, right? So that's huge. By allowing your alveoli just to be a little bit bigger, open, you're increasing the surface area and allowing for significant increase in oxygenation, oxygen in and carbon dioxide out. I also threw in here Poiseuille's law, which actually looks at the rate of blood flow through a vessel. So think of a capillary. The rate of blood flow through a capillary is equal to pi r to the 4th now by the pressure difference from one end to the other end of the capillary divided by the length and the viscosity of the fluid going through there, right? So now this is, rate of flow is related to, you guys are all laughing at me. I love it. All right, this is the only math question. I mean, this is the only math slide. I swear, there's no more. But my point in telling you this is that the radius is key. I mean, that's the only reason why I have these formulas up here, is that you can actually see r squared and r to the 4th. Even though it means nothing to you, it's just, you know, 4 times 4 times 4 times 4 is a lot different than 4 times 1. So it increases enormously. All right, the end on the math. I was an engineer before I became a doc, so sorry. Yeah, right. All right, so let's move on a little bit to more anatomy. And here's a terminal bronchiole. This is a microscopic view of it, and it goes down into the alveolar ducts into the little teeny alveoli. And you can see how tiny they are all over the place. So when you blow those up, you got great surface area. All right, so let's talk about a little bit about how does the oxygen get in. And it all has to do with pressure. So, all right, so this is probably going to not go over well either. But this is called the oxygen dissociation curve. And what this, all right, don't look at it. So what this is telling you is that at certain partial pressures of oxygen, oxygen will bind to red blood cells more easily. That's basically all this curve says. So when your venous blood comes back to the heart, red blood cells have 4 binding sites on them. say only 1 or 2 are saturated because it's coming back, it's just gone to your muscles and you've sucked up, you know, the oxygen out of that red blood cell. Maybe there's only 1 oxygen molecule bound to that red blood cell. And it comes back up into the heart and it wants oxygen. So the affinity of that red blood cell to attract the oxygen is pretty big now because it's missing all those oxygens bound to it. And as it goes through the lungs and it comes in contact with the air, it sucks up the oxygen. And then all 4 sites are bound again, and then it leaves your heart and goes to your muscles again. That's a very simplified version of how it works. There are 300 to 600 million alveoli in our lungs. A red blood cell is in our lungs for 1 second. And in that 1 second, it comes in contact with usually 2 to 3 alveoli at a time. And in a 1/5 of a second, it's completely saturated with those 4 molecules of oxygen. So, boom, instantaneously, your blood is passing through your lungs, and it should be instantaneously bound to oxygen and the carbon dioxide given away. So that's how normal lungs work. Think about somebody who's now got water all in their lungs. You know, they have 1 millimeter of water in there or 2 millimeters of water in there. That oxygen and that carbon dioxide, they're not being exchanged now. So that deoxygenated blood that's coming back is going right back out to the body. And no wonder they're fatigued, no wonder they can't breathe. And the curve is affected by pH, if they've got a metabolic acidosis, if they're really sick, they've got a bad pneumonia, they're septic, yada yada, that curve shifts one way or another, and so it does affect the ability of the oxygen to bind the red blood cells. A little bit more on airway physiology. So this is your terminal alveoli. This is where your oxygen comes in, and it's full and rich and lots of oxygen there. Here is your blood vessel. Here are those red blood cells I was telling you about. Maybe they have 1 oxygen bound to them. And then they come by the alveoli and they say, wow, look at all that oxygen. I'm binding it all up, and now they're all got 4 sites bound. So it's completely dependent upon the pressure gradient in that there is a lot of oxygen on this side, there's not a lot of oxygen on this side, and it can easily go through. The alveolar partial pressure of oxygen is 102 millimeters of mercury. The venous partial pressure of oxygen is 40 millimeters of mercury, so there's a really nice gradient of oxygen to bind to the red blood cells. This just shows it a little bit better in terms of number form. Here's your alveoli with a high partial pressure of oxygen, and here's the venous blood coming in, getting oxygenated and going out at 104 millimeters of mercury. Another way that CPAP helps is by changing the alveolar and hydrostatic pressure dynamics or gradients. So the hydrostatic pressure is the pressure of water or fluid in the vessel. If it's high on this side and low on this side, then water is going to seep this way. If the pressure is high on this side and low on this side, the water is going to seep that way, right? So what happens in CHF is you got this interstitial fluid in here. You have a high hydrostatic pressure on this side, and it's seeping from the blood vessels into the interstitial space and then into the alveoli. And what you want to do is you want to try to reverse that. So you apply CPAP. Sorry, the wrong thing. There's the capillary. This is the alveoli on this side. So the alveoli ends up moving the water. The pressure of CPAP ends up moving the water out of the alveoli, back into the interstitial space, back into the vessel, with, of course, the help of Lasix and whatever else you're giving them at the time. This is just another way of looking at how the VQ mismatch changes. Here's that collapsed lung, that atelectatic lung that I was telling you about before. And when you go ahead and put in a little continuous positive airway pressure, it blows it up a little bit so it comes more in contact with the blood vessel, and your gas exchanges are better or improved. So it improves the VQ mismatch.